and welcome to Access Denied. In 2025, an important global agreement known as the Pandemic Treaty was adopted by the World Health Organization. The goal of this treaty is straightforward. The world must be better prepared for future pandemics. After the devastating experience of COVID-19, countries agreed that we need stronger systems for cooperation, early warning, and equitable access to medicines and vaccines. But the pandemic agreement did not resolve everything. Some crucial issues were left for future negotiations because countries could not reach an agreement. One of the most important among them is the question of fair and equitable benefit sharing emerging out of rapid access to pathogen and genomic sequence. Now, when we say access to pathogens and genomic data, it doesn't mean we are passing around viruses or bacteria for fun. Definitely not. What it means is that when laboratories detect potentially dangerous pathogens early enough, before they spread widely, scientists should be able to study them. That allows researchers to develop vaccines, medicines, and diagnostic tools in advance. This allows the world to respond much faster when an outbreak happens. Valuable time in research and development can be saved, and life-saving vaccines can reach people sooner. This idea is currently being discussed under a framework called PABS, or Pathogen Access and Benefit Sharing. But here is where the problem begins. There is a deep divide between developed countries and developing countries. Developed countries want easy and free access to pathogen samples through WHO laboratory networks. These networks operate both in the global north and the global south. Once these pathogen samples are shared, pharmaceutical companies, mostly based in the wealthy countries, can use them to develop vaccines, therapeutics, and diagnostics. But these companies do not want to share the benefits that arise from the research and development on these pathogens. They want to restrict the benefit sharing only in case of pandemic. So basically, pathogens and genomic data can be accessed anytime 24/7, but vaccines and other health products will only be shared once a pandemic is declared, not when the outbreak is just beginning. In other words, the pathogens themselves are treated as global common resource, but the health products arising out of them are treated as private property. We have already seen how dangerous this system can be. During the COVID-19 pandemic, pharmaceutical companies like Pfizer and Moderna prioritized wealthy countries. Meanwhile, many countries across Africa, Asia, and Latin America had to wait months, sometimes years, for adequate access to vaccines. And that delay cost countless lives. Also, identifying pathogens is not free of cost. Countries invest huge resources in building laboratories, training scientists, and developing research capacity. Many developing countries contribute significantly to the global scientific system that detects new diseases. Yet the benefits of that work are not shared fairly. Now, reinforcing this unequal system, the WHO Secretariat, under pressure from powerful countries, has proposed creating a large global laboratory network to manage pathogen sharing. A list of around 15 laboratory networks currently functioning under WHO were disclosed during the recent negotiations. These existing networks raise serious concerns. First, the list itself appears incomplete and poorly defined. It looks as though information on existing networks has simply been collected and placed into an Excel sheet, with the suggestion that the details will be worked out later. In other words, the global community is being asked to accept a system whose structure is not even clear. Second, the question of benefit sharing remains largely unresolved. Only one network of laboratories, which is the one for influenza virus, has meaningful rules requiring the sharing of benefits such as vaccines. Most of the other networks operate more like private research collaborations with little obligation to ensure that benefits reach developing countries. The third problem: there are glaring regional inequalities. When the WHO concept note describes the laboratories that will receive and use pathogen data from around the world, European laboratories are mentioned 29 times. Laboratories in the Americas are mentioned 20 times, with, of course, the United States playing a dominant role. But laboratories in South Asia, for example, appear only 7 times. The same limited representation applies to the Middle East and several other regions. This tells us something important. The system risks concentrating scientific control and economic benefits in the same wealthy regions that already dominate global pharmaceutical production. For many countries in the global south, this looks uncomfortably familiar. This is nothing but colonialism. Raw materials are extracted from poor countries, while the valuable finished products are controlled and sold by wealthy nations. Poor countries either do not receive them or receive them at prohibitively expensive prices, at times even very late. WHO as a specialized agency should adhere to the international norms on access and benefit sharing set under Convention on Biological Diversity (CBD) and Nagoya Protocol. If the current provisions go through, it will be nothing short of biopiracy, and WHO should not become part of a scheme of biopiracy. We cannot accept a global health system where only the rich live longer, where the wealthy get medicines first, and where the lives of poor people are treated as less valuable. A truly effective PABS system must be built on equity, cooperation, and justice, not on extraction and profit.